Hello everyone, I'm Paul Atkinson from Dalhousie University and Horizon Health here in St. John, New Brunswick. It's a pleasure to welcome you to this CAEP Rounds this evening, and also to have the opportunity to mention the CGEM Just the Facts series. This is a series now that's been going on for a couple of years where we invite experts from across Canada and North America to contribute short summary articles. These are to-the-point articles giving you the latest updates in a particular area of practice relevant to emergency medicine. These can be found at the CAEP website, also on CGEM, both at the Cambridge site for another few months and also at the new Springer site. We'd welcome you to check these out. There's interesting topics there that range from a series of short reviews of COVID-related reviews such as protected code blue, managing an airway in COVID, as well as many non-COVID related pieces, including dental pain and double defibrillation in cardiac arrest. And again, multiple topics. The list of topics is growing, but we would still welcome further contributions. If you are an expert in the field, please do get in contact with us if you have an idea for the series and would like to contribute to it. So have a great CAEP Rounds and stay safe, everyone.
Thank you, Paul. Welcome everyone to tonight's session. Our work today is in the spirit of moving toward reconciliation, anti-racism, and anti-colonialism through patient-centered care, and we'll begin with a land acknowledgement. To recognize the land is an expression of gratitude and appreciation to those whose territories we reside on. As we gather today in this virtual space, we acknowledge and pay respect to the many First Nations, Inuit, and Métis people and their traditional territories on which we live, work, and play. I'd like to acknowledge that I'm speaking with you from the traditional land of the Huron-Wendat, the Seneca, and most recently the Mississaugas of the Credit River. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and I'm grateful to have the opportunity to live and work on this land. I'm Jennifer Bryan. I'll be the moderator this evening. I'm an emergency physician and mixed Black settler. My father was from Barbados and immigrated to Canada in the 1970s. My mother's family is of Irish and English ancestry and lives where I grew up in Newfoundland. I'm grateful to be joined tonight by 6 health leaders and change makers, powerful voices in Indigenous health advocacy in Canada. In a moment, I'll ask them each to introduce themselves. I do want to note before we begin our faculty and presenter disclosures. Dr. Alika Lafontaine has received meeting honoraria from the CMAJ and is a recipient of a Jewel Innovation Grant for Safe Space Networks. And none of our other faculty or presenters have disclosures or conflicts of interest for tonight. Our objectives. Through tonight's discussion, participants will be able to recognize the ongoing impact of racism and colonialism in emergency medicine, incorporate wise practices to address racism and colonialism in their own departments, define key terms such as trauma-informed care and cultural humility, discuss the role of engaging community leaders in establishing culturally safe practices. This is a question and answer based session, so please feel free to send in your questions. Marika Miskalik is our fantastic student volunteer this evening who will be collecting your questions. Now I'll ask each of our panelists to please introduce themselves. Due to unforeseeable circumstances, unfortunately, Dr. Raven Dumont-Maurice will be unable to join us this evening. Let's start our introductions with Dr. Evan Adams. Evan.
My name is Evan Adams. I'm calling in from Tla'amin territory, where I'm from. And it is so nice to see all of my colleagues here and to all of you out there. Thank you for being here. I know there are lots of places that you can be. I am a public health physician, and I've been working in Indigenous public health for the last 13 years. I'm the Deputy Chief Medical Officer at Indigenous Services Canada.
Thank you, Evan. Dr. Terry Aldred.
Howdy, thank you. My name is Dr. Terry Aldred. I'm Deketh from Clasden, a member of Lasilia the Frog Clan, traditionally known as the Voice of the People. And I'm calling in today from the Lheidli T'enneh traditional territory, otherwise known as Prince George. I'm a family doc by trade. I do outreach to First Nations communities in North Central BC. I'm also holding other hats, but I'll leave it at that for now. I'm really happy to be here. Thank you.
Thank you. Dr. Samir Shaheen Hussain.
Hi, everyone. I'm an assistant professor in the Faculty of Medicine at McGill University and work as a pediatric emergency physician in Tiohtià:ke, also known as Montreal. I've been involved in social justice movements for about 2 decades, and I'm a member of the Caring for Social Justice Collective. I wrote a book called Fighting for a Hand to Hold, Confronting Medical Colonialism Against Indigenous Children in Canada, which was published by McGill Queen's University Press in September and was just translated to French by Lux Éditeur earlier this month. And Cindy Blackstock generously contributed the foreword, and Ellen Gabriel generously contributed the afterword to the book.
Thank you, Samir. And Dr. Alika Lafontaine.
Thanks for having me. My name's Alika Lafontaine. I'm Indigenous from several ancestries. My father's Anishinaabe, Cree, and Métis, and my mom comes from the Pacific Islands. I live, work, and play here in Treaty 8 in Northern Alberta, and I'm a rural anesthesiologist. I've worked in the past couple of decades in areas of health policy and health system structure, and really excited to add to this conversation.
Excellent. Dr. Lisa Richardson.
Hi, everyone. So great to be here and to see all of my colleagues on the screen. My name is Lisa Richardson. I'm a mixed blood Anishinaabe Kwe. I'm currently in Takaranto, Toronto, but my traditional home is actually just about 4 hours north of here on Georgian Bay called Shevenoning, also known as Killarney. My work is as a general internist, and also, so I do a lot of inpatient medicine, but I also do a lot of urban Indigenous work with various Indigenous organizations in Toronto. Right now, doing a lot with Anishinaabe Health around vaccinations and mobile testing. And I am really doing a lot of work around Indigenous medical education, recruiting and supporting Indigenous learners, and strategic transformation and colonial institutions for our people. Miigwech, great to be here.
Thank you. All right, I'm very excited for our conversation tonight. Let's start with a question for Dr. Evan Adams. And so this ties into a question that we received over email. And so the In Plain Sight report described that widespread Indigenous specific stereotyping, racism, and discrimination exist in the BC healthcare system. Daniel Fontaine, MNBC Deputy Minister, is quoted as saying, "It's time for our society to go beyond simply acknowledging that systemic racism is a part of our healthcare system. We need to ensure every recommendation in this report is fully operationalized in short order, and that Métis and other Indigenous people no longer need to worry about being subject to racism if they require medical treatments." How can we move beyond these first steps of acknowledging anti-Indigenous racism in medicine to true accountability in taking action? And as part of this question, I wonder if you could address an email question that we received about really how do we define colonialism?
Great. So those of you who haven't seen the report, which recently came out, I certainly recommend that you have a look. It is quite stunning and surprising, the thousands of stories that they collected of anti-Indigenous racism within the healthcare system. But maybe it's not so surprising because a number of the informants were actually healthcare workers and healthcare leaders. And perhaps we've known for a long time that some of our patients can have racist and or colonial experiences while they're seeking help while they're in care. The report is not just startling, it actually demands that we take a strong position, not a weak or middling position against racism in our workplace. It gives about 20 or so recommendations around addressing deficiencies in governance, in leadership, in medical education, in health policy and workplace policy, and it asks for transparency and evaluation of our systems for us to really examine ourselves. And of course, I know a light has been shone on emergency rooms with the Joyce Echaquan affair and subsequent actions. I think some of us here were a part of looking at anti-Indigenous racism at a couple of national summits now, in looking at what can we do as stakeholders from many different parts of the country, from many different bodies, including as physician leaders, to make a difference. So colonialism is really like the practice or a policy of control of one people over another. You know, the establishment of colonies is quite well known. And usually the establishment of those colonies was around economic dominance, but colonization has come to mean, particularly in Canada, is a kind of a Euro-Canadian colonization and the imposition of those colonial values or Euro-Canadian values, religion, language, cultural practices, over particularly Indigenous or original peoples. And this is really not uncommon. There are at least 300 million Indigenous peoples around the world in almost 80 countries, original peoples who were often moved to the margins to make room for immigrants. And so we are living in a, I guess you'd call it a post-colonial or a neo-colonial state where we need to examine our cultural inheritance. And I always like to look at other examples. And for those of you who've been in New Zealand or Australia or the United States, Hawaii, Alaska, there are original peoples there who are struggling to have a modern existence with new countries that exist on their homelands. Canada has Indigenous roots, and how do we reckon with that? For most of us, it wasn't really a set of ideas that we grew up with. So we're trying to acquire it or catch up with it now. I think I'll stop there. Thanks.
Thank you for that, Evan. I think that's a great perspective to bring on how people are now trying to catch up, right? To things that have been known for quite some time, but maybe not obvious to everybody involved in healthcare. And that expression of a light being shone on emergency rooms, I think is a very apt one. I wonder about some of the response to that light being shone. Sometimes is some pushback. And Dr. Richardson, I wonder if I might be able to ask you a question related to that. So in your 2018 Healthcare Can report, bringing reconciliation to healthcare in Canada, wise practices for healthcare leaders, one of the wise practices you suggest is to prevent or to provide anti-racism and cultural safety education to all members of an organization. Now, for some in healthcare leadership, and like Evan is alluding to, this past year was maybe the first time that they had looked beyond the normalization of racism and colonialism and began to consider the role that we in emergency medicine might be playing in perpetuating racism and colonialism. We often hear people talk about how talking about racism and colonialism is uncomfortable and is challenging. Now, you've been able to very successfully navigate within existing health leadership structures to advocate for your patients, for your colleagues, for your learners. Can you speak to a little bit of how you've addressed pushback and what kind of advice you might have to offer.
Yeah, thanks, Jennifer. That's a great question. I think actually it's interesting. I was talking to someone earlier today about as we're seeing this awakening from the light being shone, to continue with Evan's image there. We're seeing an awakening to people who've never necessarily thought about this or experienced racism and discrimination. But we're simultaneously seeing, I think, an emboldening of people to push back and to resist it. And so this this act of teaching about racism and anti-racist practice is particularly important right now. Whenever I speak about education, though, I do like to remind people that education alone is not enough. So education needs to be part of a larger strategy that deals with governance, leadership, recruitment, ways to process and manage complaints that occur. But education is critical, because what that education does is it causes an awakening for people who may not have actually seen or thought about how racism is playing out literally at the bedside, in the choices that one may make, in the referrals that one makes, in the decision making. And so through that awakening, you start to say, wow, I had never thought about that before. I never even imagined. The video of Joyce Echequan for so many, I think, was devastating, but also illuminating to think, how can anyone have been treated that way in our healthcare system? But what must actually happen with that awakening, with the educational process, is the move to action. So that with that awareness of what's going on comes the act to actively change, not only your own practice. So not only to actually literally interrogate the decisions that you're making when you're seeing someone, your clinical judgment, to say, is there something else that's playing in? Is there a reason why I'm choosing not to, why to discharge as opposed to admit? Would I do the same thing if this were my mother, loved one, or the CEO of the hospital, for example? So really starting to always be reflexive in your practice, but also to make changes at the system level within your organization. So how are you collecting collecting complaints or experiences of mistreatment? Are you looking at who you're hiring and your hiring practices? Are you recruiting Indigenous providers? Are there Indigenous leaders in your organization? So that move from actual awareness to practice is really critical. And once people the act of negotiating resistance is difficult for all of us. But the way I often frame this is, when we build health systems to support our people and others who have been most structurally marginalized by the programs that we have, we actually are building programs that will be better for everyone. So recognizing that to support and elevate, and this is a teaching that I've had from an elder with whom I work very closely, if we elevate the well-being of those who are at the lowest, experience the lowest, the poorest quality of care, the level of care that everyone receives is better. So those are just a couple thoughts around education and moving to action.
Excellent. All right. And I think that for our audience tonight, seeing some of the other questions that are coming in, that's exactly what so many are looking for, is now for those who have moved from not being able to see the impacts of racism and colonialism in care, now being able to appreciate those in practice, and now saying, okay, well, now what do I do? Right. Yeah. I wonder actually if Dr. Shaheen Hussein, I think the process of that awakening that Dr. Richardson just spoke to, I think you've got a very good example of that in your book. So your book, again, Fighting for a Hand to Hold, Confronting Medical Colonialism Against Indigenous Children in Canada. You speak about the systemic racism at the root of the practice of separating Indigenous children from their families when transporting them for care. And you quote a former PEDS resident who wrote, "I can't even recall all the times in my residency that I was in a situation where this policy affected a child I was taking care of. We knew it was the rule, we knew it was awful, and yet we just kept going." Can you speak a little bit to how you made this step to seeing the racism at the heart of this practice, and how other emergency physicians might be able to denormalize systemic racism in their own settings?
Yeah, I mean, I've been thinking about how best to respond to this question, and I wish I could say that it was always obvious for me from the outset that the non-accompaniment practice was racist, but to be honest, that wouldn't be true. Aside from my first year of pediatric residency at McMaster University, I did all of my medical training, including pediatric fellowship, with a focus on acute care medicine at the Montreal Children's Hospital. So I was probably involved in the care of dozens of these, EU or Cree and Inuit kids transferred from Northern Quebec alone. And the Children's Hospital had certainly taken care of hundreds of these kids sent alone over that same time span. And all of this had basically become normalized for us over time, no matter how upsetting it was to see these kids sent alone. And it kind of brought up the point that, inflicting emotional and psychological trauma on children should never be normal. Yet I never really questioned the practice itself, even though I saw the trauma. I guess I assumed, like the former pediatric resident you quote, that this was the rule and that's just the way it is. Even when a colleague of mine in the emergency who had done a chunk of his training at BC Children's had brought up on more than one occasion that this was a draconian practice, his outcry didn't compel me to act. What eventually compelled me to act was being the high care physician involved in the care of two Inuit kids who were transferred alone to our emergency from Nunavik a few weeks apart in the summer of 2017. And those two kids, for a reason I still don't really understand, really got to me. And, they presumably both did okay from a medical perspective, but I was haunted by the emotional and psychological trauma we had caused them. And by we, I mean physicians and the entire healthcare system, whose mantra is supposed to be, primum non nocere, above all, do no harm. Yet we caused harm, and maybe not intentionally, but by going along with a system that did. And those two kids were the catalyst for the Hand to Hold campaign that eventually resulted in ending the non-accompaniment practice. But just to provide a bit of context about the practice itself, it affected kids from rural and remote regions across the province of Quebec. But for various reasons, kids from Northern Quebec, Indigenous children from Northern Quebec were disproportionately impacted. And so even if the practice may not have initially been intended to discriminate against Indigenous kids specifically, that's certainly how it played out, especially when multiple calls for change, often led by impacted communities themselves, were ignored. So anyway, to go back to actually answering your question, the first part of your question, it was actually another colleague and CAEP member, Dr. Brett Burstein, who helped me to take an important step at realizing the racism at play in this practice. He basically got in touch with me after the first kid who was sent alone, whose care I was involved in that summer of 2017. And he asked about how the child ended up doing, because I was the trauma team leader and he's involved in the trauma team at the Children's Hospital. And when I brought up the fact that it was infuriating that a kid, would be transferred hundreds of kilometers away from home without a caregiver, Brett's email reply was succinct, but really disarmingly accurate. He basically said the root cause, unfortunately, is systemic racism. And what I find really interesting is that I've been involved in solidarity work with Indigenous communities and initiatives rooted in anti-racism and decolonization over years. And yet it took a very candid observation from Brett to make me realize how insidious these kinds of practices, rules, and policies can be in healthcare. Insidious but systemic. Insidious, systemic, and very pernicious. And so to respond to the second part of your question about denormalizing systemic racism, and Lisa and others have touched on this already, I guess one of the most important aspects is adopting, a cultural safety approach, which fundamentally involves a lucid analysis of power relationships in healthcare. It means recognizing we're never really neutral, and that historical, economic, and social contexts have a direct influence on health and healthcare services. It means shifting our lens from the individual that is so central to the biomedical model instead to focus on the social, economic, and political positions of certain groups within societies, including physicians and the power we wield. And it means not only that we have to critically reflect on our cultural heritage as part of the medical profession, but also that those of us who are settlers here, despite our own complex histories, must confront the very real history of medical colonialism, which continues to this day. And by medical colonialism, and this goes back to Evan's reply about colonialism more generally, I'm referring to a culture or ideology rooted in systemic anti-Indigenous racism that uses medical practices and policies to establish, maintain, and or advance a genocidal colonial project. And so to go back to your question, the former resident's comment is really insightful for us on so many levels. We knew it was the rule, we knew it was awful, and yet we just kept going. And at the end of the day, we can no longer just keep going.
Thank you. I wonder, actually, Dr. LaFontaine, so a lot of what Dr. Shaheen Hussein is talking about has to do with how the status quo is maintained over time. And you've done some really insightful work and done some fantastic discussions about the maintenance of the status quo. I wonder if you could speak a little bit to what do you mean by the status quo, and what are the things that we might see in the emergency department that are so normalized that we don't realize anymore that they are actually reflective of racist and colonialism practices, much like that realization that Dr. Shaheen Hussein described.
Mm-hmm. Yeah, it's a good question, and I hope people who are watching see how all of these comments layer on top of each other. Like none of this makes sense if it's isolated by itself, right? You have to see the whole system in order to see the whole system. I know in the area of practice that I do, acute care, which overlaps quite a bit with emergency medicine, often we work long hours. We're in highly stressful situations. We're doing things that literally save lives day to day. But in the course of it, we actually do a lot of racist actions. We discriminate against people and their ability to have choices. We shame them when they question us. We don't trust them when they tell us about their medical history. We don't answer their questions. We don't give opportunities to certain types of medical access because it's inconvenient for us. Or we think to ourselves, oh, well, they're not going to want that anyway. I remember in Saskatchewan, there was an epidemic of amputations of, 20 to 30-year-old males in Saskatoon. Mm-hmm. And I don't think it's ever really been unpacked that one of the reasons why amputations were done is several people had the impression that, oh, well, they're not going to take care of their wound anyway. Oh, there's no fresh water where they're from, so they can't keep it clean. So I'm doing them a favor by removing their limb. And I think one of the core questions that we need to ask whenever we ask about the status quo is who exactly does the status quo help? If it speeds up your workday, if it makes your decision-making process easier, the status quo is not helping the person in front of you, it's helping you, right? There's a policy within Saskatchewan that there was no investment of First Nations in First Nation communities as far as infrastructure for many, many years, up until I think it was 2017 when they re-explored it. And when you think about who benefits from that status quo, if you don't invest in a location because of a policy, that's actually a cost saving. So if you look in Saskatchewan with demographics, 1 in 5 Indigenous patients are part of their demographic. You're actually saving money on 20% of the people that need care. And so when you look at colonialism and the way that we practice, colonialism, I feel, is really sustained because extinguishing the rights of Indigenous people is what's best for everyone except for Indigenous people. And so it's no wonder that we have systems then that take away people's voice. It's no wonder that we have systems that remove their position at decision-making tables, and why the healthcare system has so much crisis that kind of gets produced as part of that. Just one quick note about the status quo. The status quo is us. And I think we shouldn't forget that systemic racism means us. We're the system. I remember in residency, at a lot of C-sections that I did, whenever they had tubal ligations as well, the women would often start crying after they told them that they were going to clip their tubes. And I never thought about this until Senator Boyer started the investigation into tubal ligations and forced sterilization in Saskatchewan. And when I sat there, and remember, I'm someone who experienced racialization. I taught on racism and anti-racism. I advocated in behalf of patients who experience these things. Yeah, I never questioned whether or not, the patient had been involved in a meaningful informed consent. Whether or not they had actually been asked, do you want to be sterilized or not? And looking back on all those different experiences, I have a completely different perspective about what I actually was a part of. And for myself, and I expect for many people who come to that realization, like it hurts to think to yourself, look at all the harm that I let happen. Look at the harm that I'm creating day to day. And as physicians, that's especially hard because a lot of our identity is wrapped up in advocacy and altruism and doing good. I mean, there's not a single one of people that are a member of this tonight that I think go to work and are just really happy when a patient gets harmed, but that is the reality. And it's painful to come to that realization and then have to rebuild like a different kind of person and come to grips with the harm that you were a part of. We all inherited these colonial systems. It's not anyone's fault that we live in colonial Canada. We did not create these colonial systems, but we sure perpetuate them if we don't stop what's going on.
Thank you so much. One of the examples that we're seeing right now and that has prompted a lot of discussion around racism and colonialism in Canada are the discrepancies in rates of COVID infections in racialized communities. And Dr. Aldred, I wonder if you could speak a little bit to the experience that you spoke about in getting your vaccine, and Dr. Richardson, in your experience in working with Anishinaabe Health on the vaccine program as well. Now, Dr. Aldred, there was an article by the First Nations Health Authority with Dr. Kelsey Louie. And you were quoted as saying that after you got the vaccine, I think like so many of us who have, it was like you were seeing a light at the end of the tunnel and that you felt hopeful and optimistic. There have been concerns about Indigenous patients mistrusting the vaccine, and a response from many, including some on the panel tonight, that this should be reframed as or reframed as a comment on the trustworthiness of medicine, given the historical and ongoing impacts of anti-Indigenous racism, including the examples that Dr. LaFontaine just discussed. Are you concerned, Dr. Aldred, about vaccine hesitancy amongst Indigenous patients? And what kind of a role do you see for physicians?
Yeah, thank you. And it was a metaphorical light, not a side effect from the vaccine, just to clarify. So certainly, am I concerned about vaccine hesitancy? Yes. But I think I'm concerned in general, at the heart of it, I believe that vaccines are good medicine. But I do recognize that there is a lot of colonial history with forced or coerced experimentation with Indigenous people, including, nutrition experiments and residential schools, things that were done at TB asylums and Indian hospitals and the like. And so I understand why people are hesitant, and I think we could do a better job at prefacing why Indigenous people have been put in priority one. And that is around a lot of fierce advocacy by people like Evan and Lisa and, Alika and to say that, due to colonization and colonialism, you know, with the increased burden of disease, that, you know, Indigenous people would, you know, could have worse outcomes from COVID, and therefore would benefit from having early access to the vaccine. And that's especially true in our more rural and remote communities. And so, so I think that with the education around that we're actually fighting for the right to have the vaccine. And certainly in other countries, Indigenous people haven't been given priority for a lot of different reasons. And so, but then also just education around, you know, the process that the vaccines went through to get approved, and, you know, having open and honest conversations about, you know, the possible side effects, and the risks and benefits. And in the case of the vaccine, I do think that the benefits outweigh the benefits of the vaccine outweigh any risks, especially with, you know, the more of what we're learning about COVID and the potential long-term complications of it. And so, but I think that with education, and I've been involved in a number of conversations with individual communities around BC, and, you know, once they have a chance to ask their questions and talk to physicians that they trust, or other healthcare providers, and really be able to have a really good and dialogue, you know, I've had a lot of times where people who were really hesitant at the beginning, at the end, were like, you know, really open to getting the vaccine and felt very reassured. And so I think, you know, I think education is really key, and being able to have those dialogues, I think, is just so important, especially, you know, with people that they can trust.
Thank you. And I wonder, Dr. Richardson, in listening to Dr. Aldred's response, the role of Indigenous physicians in leading these conversations is clearly incredibly important. And I was struck by a tweet that you sent. I think that's what you say. You sent a tweet earlier this month about Indigenous medical students who had approached you for advice. And they had been very hesitant about discussing their interest in Indigenous health as part of their application letter for residency training. And you described that as disheartening, but not surprising. So I wonder if you have any follow-up comments to what Dr. Aldred said about the vaccination program, and then second, thoughts that you have about the path for Indigenous students pursuing careers in medicine.
Thank you. That's such a great question, and I really want to echo what Dr. Aldred was saying around the education piece. I've been involved with some pretty exciting the development of exciting educational materials specifically for Indigenous peoples. It's been a large collaboration with many people, and we have these fireside chats with Indigenous docs who or nurses or traditional healers and elders who've had the vaccine, and they talk about the decision-making process and talk about maybe the points of resistance that they had and how they made that decision. And we've had incredible feedback on that material. People want to know and understand the rigorous testing that the vaccines have gone through, and, you know, the expected side effects, et cetera. But I've been involved in a couple of initiatives as well, where we've done vaccinations, and one was through Anishinaabe Health Toronto, where we actually went into Wigwamin Terrace, which is an Indigenous retirement home here in Toronto, and we vaccinated 125 elders and seniors, and there was not a single point of resistance or concern, because we had had a lot of great conversations earlier around the consent process. This was an entrusted Indigenous organization that was coming in. We had smudged before. There were many community members and leaders who were there. And honestly, it was, people were so grateful. And secondly is an initiative for part of the Northern Outreach, where in those communities in Northern Ontario where they have had Indigenous health providers from the community specifically, the uptake rates of the vaccine were 98% of those who were eligible. So that trust that is built when we have our own people, particularly from your local community and nation, who are there to educate and share, is cannot be surpassed. Like, it's so critical, which is why we need more Indigenous physicians and healthcare providers, which is why when I have these learners who are coming up to me and saying, I want to apply to this program, emergency or family med or internal med, and I'm not sure if I should actually talk about my identity, I feel so upset. But of course, as you alluded to, this is well known because we have documented the ongoing experiences of racism that Indigenous medical learners experience. They're told, people assume they've come in through an easier pathway, that they are not as talented, and they don't necessarily haven't merited what they've achieved, when in fact what we know is the distance traveled is much more significant for many of our learners. And I mean that in a metaphorical way and sometimes in a literal way as well. The barriers that people have overcome, the kind of minority tax of mentorship, all of the community work that's expected is clearly an example to me of someone who does selection of residents into our program, of the exact kind of resident whom we want to recruit, someone who sees health in a different way and has really centered community through so much of their work. So I think that's the work that we need to do around educating our program directors, our deans of admissions, and others. That's it for my reflection there.
Thank you. And Dr. Richardson, one of the issues that you mentioned is around the myth of meritocracy, right? And so I wonder if anyone on the panel would like to speak to what that is and how that impacts medicine in general, not necessarily emergency medicine in particular, but what is the myth of meritocracy?
Hi, it's Evan. I just want to relate from the anti-racism report that a number of the Indigenous health professionals questioned how much racism they received in the classroom and what was the selection process, that so many of their colleagues in the classroom were terrible at understanding or identifying racism, and were just casually racist in the classroom. I found that shocking that it just seemed to be such a common issue for them, that they would experience racism almost to a person, racism. And so you have to kind of forewarn Indigenous medical learners, someone's going to say some terrible crap to you, and you mustn't let it discourage you from finishing. So I just wanted to put that in there. And I'm just remembering a tweet where a teacher was saying about a medical student. Medical student said, well, "What if I feel uncomfortable serving gay, lesbian, bi, trans patients?" And the teacher or the mentor said, "Well, maybe you should find another profession." And it made me laugh because I thought, well, why are you here trying to be a medical professional in Canada if you can't serve the Indigenous people of Canada well? Like, you'd think that they would be eager to learn to have those skills, because we are part of Canada. We're actually an integral part of Canada in a significant proportion of the population. Why would you want to go in with a bad attitude and very simplistic notions of who's in front of you?
I think that speaks a lot to the importance of mentorship, of modeling, right? So depending on who that student was speaking with, they may have gotten a very different response, right? So I think that's a fantastic question to bring up.
And I certainly don't advocate that kind of roughness with students. I think we have to be very kind to them and treat them like our children. It was just a moment where it was illustrative for those of us who teach, because certainly we've all been there, and you know, it's surprisingly easy to be gruff and rough with those with less power than.
Yeah, I wonder, just in speaking about mentorship and leadership, Dr. LaFontaine, you've done a lot in terms of discussing sponsorship in building leaders. And I wonder if you could speak to us a little bit about that work. In particular, you had a paper from 2018 called A Retrospective on Reconciliation by Design. And you talked about applying alignment thinking. Can you tell us a little bit about what that is and how it applies in medicine?
Yeah, so there's lots of different types of thinking that's applied within kind of health transformation models. There's system thinking, which is your classic like root cause analysis. I mean, we all kind of go through this as we diagnose and break down narratives within patient experiences that we are able to be a part of as we diagnose, et cetera. And then there's design thinking, whether or not the system is actually created to benefit the user, right? Alignment thinking takes elements of both and combines it into kind of a storytelling mechanism for change management. But I'm going to speak to a past question that you asked, the one about meritocracy, and then kind of advocacy and leadership, because I've been talking to lots of medical students about this in the last month. We've all heard of the Peter principle. You know, you're eventually promoted to a level where you're incompetent. I think all of us in this area of limited health resourcing have experienced incompetent decisions, at least from our point of view. And I think meritocracy makes the assumption that the person who they think you are will immediately be successful within the area that you get promoted to, when in reality, they don't look at outcomes at all. You know, meritocracy is the biggest problem in places that don't actually look at the impacts of leadership decisions. They just assume that the people at the top are competent, even though the whole system is falling apart around them. I think that this is common within racialized systems. When you have patients who repeatedly come back and say, you know, I've had a bad experience, I feel racialized, etc., and then the feedback from leadership is, well, you know, so-and-so has this background and has been in this position for 20 years, so it must not be a problem. And so that's a partial answer to your meritocracy question. And I've been spending lots more time with medical students talking about the differences between advocacy and what's actual leadership. And I think it's important to understand this, especially as clinical staff, persons who actually provide care. So advocacy is bringing your own lived experience and bringing forward, you know, your needs, your rights, your challenges, asking for the system to kind of address what's going on with you, right? And whenever someone needs something within the healthcare system, advocacy is extremely important. So thank goodness for advocates who actually come forward and say what they need. When you have group advocacy, you usually find some sort of ally who has space within the system, and then they put their efforts behind you, kind of move forward your issues, your lived experience. And then systems advocacy is how do you change the lived experience of other people like you at a systemic level, you know, trying to attack legislation or policy or procedure or workflows or other things like that. Leadership, on the other hand, has very little to do with advocacy when operationalized properly. Leadership is bringing in other people's lived experience into your tables of power. You know, it's not about you within your position, it's about everyone else. And I think within the healthcare system, we often have mixed leader advocates where we bring our issues to people and they mix it in with their own issues. And then they hope that in addressing their own issues, they solve yours as well. And I think particularly when it comes to racism and persons who don't have lived experience, who don't understand racialization, And I mean, we often use the term woke, like someone who's woke still has not experienced racialization. There is no such thing as putting on racialized shoes by definition, because you're not from that race, you're not from that lived experience. And when we look at leadership and the merits of our leaders, I think it's important for us nowadays to sit back and ask, like, who are they actually letting fill their spaces? You know, at the federal leadership meeting, you know, my own personal experience with the presentations was I had some time set aside for, you know, presenting, and they put me in with the National Association of Friendship Centers, you know, and speaking with the person who presented there, there was some stress about not having enough time to present things. So I just ceded my space, you know, so they had the full time instead of having me and you know, the person split up that time and possibly dilute the message. You know, and the space that I have still exists after the meeting. I still get the opportunity to inform policy. I still get the opportunity to participate in discussions around how things move forward. But maybe that space will be the only space that that person has at that table at that time. Mm. And, you know, people often ask, well, what can we do in order to move forward anti-racism within patient care? Well, you have where you stand right now. You have your role as a physician. You have your space when you call for a consult. You have your space when you talk to someone who's getting transfers for surgery, and you can fill that space with someone else. You know, if your patient has a question, you don't necessarily have to filter that. You can facilitate direct communication between that person and, you know, the other persons who hold those levers of power, and then help them navigate those spaces. And so I think in the future, and what I'm hoping we'll have in the future, is more and more of a system where our leadership cedes the space to people who haven't had a voice. And we hear more and more advocacy because we're creating more places for it to happen. You know, otherwise what happens is we have this advocacy system where we're all competing with each other because we all have different lived experiences and we all are trying to get heard. When in reality, it's a big table. We just need to bring more in.
Fantastic. So, excellent thought about creating space as a practical step for physicians and learners that are listening today. Lots of other ideas for next steps for those of us in emergency medicine across the country. We have just a few minutes before we do wrap up. Our conversation has gone so quickly. I feel like I have 50 more questions for each of you. But I wonder, as a last comment from each of you, if there is a specific next step that you would suggest for emergency physicians and learners who are listening to this conversation today. Maybe we can start off with Dr. Aldred.
Thank you. You know, I think I'll finish by saying, like, I think the Racist Anonymous approach is a good approach to say, as Alika was saying, you know, we inherited a racist and sexist, you know, culture. And it's not our fault, but we all have biases, implicit, explicit biases, and really the only way to identify that is to have a strong reflective practice where you critically reflect on your clinical decision making, things that happen in your practice, and to help to uncover that. And what's even more powerful is if you can find a good group of people who you trust to be able to do that, so that if there's a big blind spot for you, maybe somebody else can point it out. And being able to create those relationships where, you know, everybody feels safe, where their respect and integrity remains intact, but you can hold one another to account. And be able to own your experiences, but also own potentially your behavior or decisions and the impact that they may have that is probably unintentional, but very real for the people receiving care. And by doing that, we help to cultivate our own cultural awareness, our own cultural humility, which hopefully will make it so that the people experiencing care describe it as culturally safe. We can't describe ourselves as culturally safe. Our patients need to do it for us. So I'll leave it there. Thanks.
Excellent. Thank you. Dr. Shaheen Hussain, do you have a last comment?
Yeah, I mean, I was just kind of also just thinking back to your question about meritocracy, and I mean, everything people have said is really insightful, and I feel like one of the things that I find interesting, whether it was going to medical school, residency, or as a staff, is this persistence of this myth of meritocracy. It really kind of pervades everything, right? Like, and it impacts people on different levels, and it reinforces people who are in power, and it makes life really difficult for those who are not in power, obviously. And what's interesting, though, I guess for for an audience like this, for CAEP, is that to me, meritocracy as a concept in the current system is a paradox. Like it's a contradiction if you accept the social and structural determinants of health as being a real thing, right? Like if we acknowledge that the social determinants of health are real, which I mean, clearly the medical literature is unequivocal on that at this point, then the fact that a child who's born in a northern community, in the inner city, in different contexts, has a different life expectancy than other kids who were born in more privileged backgrounds, that in and of itself undermines the very foundation of a meritocracy, because it has nothing to do with how hard that person's going to work, because everything is stacked against them. And so I'm in terms of my closing thoughts, I guess one of the points I want to highlight, I guess, is this idea that inequalities in healthcare follow the fault lines of societal injustices. And unfortunately, Dr. Raven Zummo-Morris wasn't able to make it this evening, but I think she would have mentioned Joyce's principle, and it was mentioned earlier today. The brutal death of Joyce Echaquan happened because these societal injustices continue. And so I guess my hope or my message is really for us to go beyond oftentimes the walls of healthcare institutions to be able to affect change at a more societal level, because the hope would be that would actually bring about more meaningful change over the longer term.
Thank you. Dr. Adams, last thoughts?
Thanks very much. I think, in our post-colonial realities, it's just a word, post-colonial realities, we have to rethink our relationships as Canadians with Canada's Indigenous peoples. The original treaties that Canada struck with Indigenous peoples meant that we agreed to walk together, but separate. And I think of physicians as public servants, and that we support Canadian society. I feel like we have an obligation as physicians to re-examine our relationships with our Indigenous clients and with our Indigenous colleagues. That the old way of doing business is just not quite enough. And I think in the spirit of reconciliation, where Canadians make peace with the history that they inherited, and that had some truly terrible and horrible aspects to it, that we as physicians are able to face that reality. It's much better than living in some strange, unaffected reality of dominance and not ever having to take into consideration others' realities. So I'm quite excited by the thought of reconciliation and the role that physicians can play.
Fantastic. All right, and Dr. Richardson, you'll have the last word for the panel. Thoughts that on what you would like the emergency physicians and learners and nurses and allied health who are listening in. What would you like them to know or to do based on our discussion tonight?
Well, it's really hard. There's so many things that I'm inspired by the words of my incredible colleagues here. You know, I'm going to come back to something that I've spoken about in lectures and other fora, and that is the idea of deep listening, which, you know, is a concept that's been adapted here by Indigenous folks, but initially also articulated by colleagues in Australia, Indigenous Australians. And so listening is, we need to listen for those voices, as Alika said, that are not heard. We need to, but it's more than just listening. We actually need to create the spaces and the structures where where people's voices, our community members, are heard, and then create the structures where we or they, all of us, act together towards reconciliation by always holding self-determination and at the heart of any decision that is made that affects Indigenous peoples. So recognizing Indigenous rights means creating the space where those rights can be enacted in the healthcare setting. And that means Indigenous peoples leading, guiding, and moving forward, because we know how to heal ourselves.
Excellent. I think that's a fantastic way to end our session tonight. I want to thank all of our panelists this evening, Dr. Evan Adams, Dr. Terry Aldred, Dr. Samir Shaheen Hussein, Dr. Alika Lafontaine, and Dr. Lisa Richardson. Thank you to the CAEP team for the opportunity to have this important discussion with emergency physicians across the country as part of the National Grand Rounds. In particular, thank you to CAEP President, Dr. Kirsten Johnson, Dr. Paul Pajo, Gail Chapman, and Jeff Allen of Jeff Allen Productions. Thank you all for joining in on the discussion tonight. Thank you to those who sent questions that prompted discussion. Hopefully this has prompted reflection and will lead to further conversation and action within your own emergency departments. So thank you all again. Stay safe and have a good night.